Hello, everyone. Nice to see you back. And I think we will have we will start the second semester TEIN lecture series from now on. And I think every Wednesday we will have a lecture series. So at this semester we have composed some correlative imaging sessions, and actually it has been done 2 years ago, maybe. So I think some parts might be overlapping and maybe repeated. So I think some of you participating in this lecture series might have already have heard some contents, but I think it might change. So, and then at October, there will be a regional training course by IAA and hosted by Indonesia in Jakarta. And sorry for. Yeah, so there will be a regional training course, and thanks to the IAEA and our host and the participant, Dr. Hendra, kindly invited our TEIN colleagues can also, I think, involve in this regional training courses. And after that, we have composed some sessions for interactive sessions by each country. So I think there will be experts from each countries will deliver us lectures in this period. Okay, so today, and I'm very sorry for changing the schedule for today's lecture. So, okay. So today, what I would like to share is about the correlative imaging, and especially for the stomach cancer. Okay. So if you have any questions or comments, you can just really turn on your mic and ask, or you can just write on the chat, so that we can discuss, or we would have some discussion time after this lecture. Okay. So as you will know that the stomach cancer has a high, it is the 5th most diagnosed malignancy worldwide and 3rd most common cause of cancer-related deaths. And incidence is, as you can see, high among Asian and East Asia and East European and South America. So actually, most of the mortalities are coming from like China, Korea, and Japan. So we have a lot of cases for stomach cancers. And so firstly, the anatomy of the stomach is what you might need to remember is the difference between the esophageal cancer and the stomach. So definition of stomach has changed from the 8th edition of AJCC. Previously the margin was 5 centimeters. However, now it is defined as if the epicenter of the tumor is within 2 centimeters of the esophageal gastric junction and invades the esophageal gastric junction, it is classified as a esophageal cancer. So now you can see that if the center is within the 2 centimeters, it is now defined as esophageal cancer. And the The gastric wall has composed of 5 layers, which is okay. Let's just wait for a while. So the 5 layers are lamina propria and muscularis mucosa and submucosa and muscularis propria and subserosa and serosa. And using the sono, it can be seen as a so these 5 layers can be seen. So it is now widely used to detect to define the T staging of the cancer. So actually CT has been well used for the T staging and detection of the stomach cancer. However, as you can see from the multi-detector contrast enhanced CT, only 3 layers of stomach wall can be discernible, and which is, as you can see, mucosa shown as very high intensity, and at the middle, like as you can see, it's a lower intensity is the submucosa layer, and at the outermost is which is relatively higher than the submucosa layer is the muscle and serosa level. The normal thickness of the gastric wall ranges from 5 millimeter and when adequately distended, and it can be 10 millimeter if the distension is not well done. So, and when the thickness of the gastric wall exceeds so 1.5 centimeters, so 15 millimeter, it may be suggestive of malignancy. However, this is when the distension is well done. So you need to note that a mass-like appearance is often seen at the gastroesophageal junctions owing to the oblique course of the distal esophagus. So these kind of pseudo thickenings are seen, and you might need to remember about these. And more importantly, there should be a proper distension is necessary for diagnosis of the stomach cancers. So we can now see how in the 8th edition of AJCCT stagings are done, and it's based on the invasion, how the invasion has been. So, and at the T4, firstly, T1 is when the tumor invades into the submucosal layer, and T2 is if it extends to the muscle layers, and T3 as a subserosal and connective tissues. And T4 is, as you know, when it invades the serosa or adjacent structures. And here, what the adjacent structures are, organs are like spleen, transverse colon, liver, diaphragm, pancreas, abdominal wall, and these are the adjacent organs. So firstly, T1A staging is when the tumor invades lamina propria or muscularis mucosa. And T1B is when tumor invades the mucosal layer, as seen from the CT scans. And T2 is when the tumor invades the muscularis propria, and it destroys the low attenuating strip, so outer layer. But when it is confined to the gastric wall with the smooth outer surface, so the gastric wall surface is smooth in T2. And T3 stage is when the tumor penetrates subserosa connective tissue, and there is a transmural thickening and enhancements with the smooth outer surface of the gastric wall. And T4 is, as we have shown, that there is an invasion of to the serosa level, which is the visceral peritoneum. And so there is also a transmural thickening and enhancement. And as it invades the other adjacent structures and the serosa level, the outer border of the gastric wall is irregular, or there can be a nodular and perigastric fat infiltration in this T4 stage. So, and one thing that you might need to remember is there are ligaments that connect the stomach from the adjacent organs, and this and so the subperitoneal space is a continuous interconnecting space beneath the peritoneum that contains the ligaments, mesenteries, and suspended abdominal pelvic organ. And because of the interconnection, ligament can serve as a route for tumor spread. So as an example, gastrohepatic ligament can serve as a spread to the hepatic lobes. And this hepatoduodenal ligament can serve as a route to spread to the hepatic lobe, or also in the pancreas head areas. And gastrocolic ligaments are, as named, as you can see, are connected, and it can spread. The tumor can spread to the colon and omentum by these ligaments. And gastrosplenic ligaments can be a passage for the spread to the spleen. And I think these splenolenar ligaments can serve as a route for the tumor spread to the left side of the abdominal cavity and pancreatic tail and descending colons. So these parts can be might need to be well detected for the detection of the tumor spread and tumor metastasis. So T4B stage is when it invades these kind of adjacent structures. And as you can see from the image, a wide obliteration of fat plane between gastric tumor and adjacent organs are seen. And in this case, through the hepatoduodenal ligament, tumor invades to the proximal part, the head and body of the pancreas. So as you can see at the right decubitus position, you can see the sliding sign is not visualized, reflecting there is some obliteration and invasion in addition to the pancreas head areas. So then, what kind of function or what kind of the role does the PET, FDG PET can do in the staging workup of the stomach cancer? To know, before that, we might need to know about some physiologic patterns of FDG uptake. Firstly, there are, as you have when you review a FDG PET, there is a physiologic uptake are normally seen in the stomach. And normally though, it is the FDG uptakes are more seen in the upper part. So the cardia area, and there is less, but some middle uptake in the middle body areas. And in the antrum, there are normally low uptake. So there, like if there is a hypermetabolic lesion in the antrum area, it might be more, can be more suggesting of tumorous conditions or inflammations. So we can actually recall that lesion. However, in the cardias, there can be more of a physiologic uptake in the stomach. So there can be some, you might need to remember those differences in the physiologic uptake. And some interesting point of the FDG PET in the stomach cancer is that the uptake pattern is different according to the histology type of the cancers. And these are some classifications of how the stomach cancers are classified. And usually it is classified like intestinal type, diffuse type, mixed, and in the WHO criteria, it is like intestinal types are also can be classified into papillary, tubular, mucinous, and diffuse type can be as a polycoesive, or which includes the signet ring cells. And like in the Japanese classification, it is also similar. So what are the characteristics of this histology type? As you can see, is the moderately differentiated adenocarcinomas have a higher uptake compared with the signet ring cell types. And also intestinal type of the tumor has a higher uptake compared with the diffuse types. And as one more thing is that, as you can see, the size of the tumors are also a factor for FDG uptake. And as the size is bigger, there can be more chance of higher FDG uptake. So as you can see, this kind of intestinal growth pattern tumors can have more chance of higher FDG uptake. And these kind of diffuse, like Borman type 4 cancers and diffuse infiltrative tumors, like polycoesive carcinomas, can have a low FDG uptake. So this is some summary of the characteristics of the FDG uptake patterns in the stomach cancer. So low FDG ability can be more seen in mucinous signet ring cell, diffuse type, and Borman type 4, and fully differentiated carcinomas. And usually in the tubular or intestinal type, Borman type 1, moderately differentiated carcinoma shows relatively higher FDG ability. But the problem is that usually the FDG uptake in FDG ability in the stomach cancer is low compared to the other tumors. So this is a case of 52-year-old male patient with a abdominal discomfort. And in the EGD, there was a finding of the gastric ulcer. So our physicians have done a biopsy from this ulcer. Before that, the patient underwent FDG PET, and as you can see, there is some inflammatory lesion in the lung. And also, as you can see from the PET image, there is some thickening in the antrum areas. However, we cannot see definite discernible hypermetabolism in the scan. So, however, in the CT, you can see a wall thickening and in the antrum with the Borman type 3 ulcerative lesions with which has a very non-discernible uptake. And the biopsy has confirmed it as a poorly occlusive carcinoma, which may have the low FDG ability. And case 2 is a 72-year-old male patient with, say, abdominal discomfort, and the EGD confirmed it as a gastric cancer. And also for the staging workup, the patient have done FDG PET. And as you can see, there is a so there is a maybe reactive lymph node in the right interlobar areas, and also another hypermetabolic regions are in. Actually, as you can see, there is some for the hepatic lesions or the gastric lesions, abdominal lesions, there is some problem for the registrations. And then I think this patient also have some registration problem, but there is a high, as you can see in the MIP image, there is a hypermetabolic focus in the antrum area. So we can refer it as a gastric cancer. And there was also, as you can see, sorry, it is not properly registered, but there are some lymph nodes in the adjacent pyloric area, so peripyloric area. So we could also refer as there is a nodal metastasis. So you can see that the registration is not well, but there are several nodules in the peripyloric areas which can be seen. And also ulcerative lesions in the CT scan with some necrotic lymph nodes can be seen. So this patient was diagnosed as a stomach cancer with nodal metastasis and the node metastasis. And it came out from the after the proximal gastrectomy. It was confirmed as a tubular adenocarcinoma with moderately differentiated. And the histology type was, by Lauren, was the intestinal type, and the depths, as you can see. So this indicates that these kind of tumor can have a higher chance to have a high FDG ability. Still, as the T staging itself is limiting because of the resolution of the FDG PET. So CT or EGD-based sonars are used for the T staging. And however, the detection of the primary lesions have quite high sensitivity and specificity, but usually the specificities are higher. And as easily detection rate of the AGC is more higher than the EGCs. And more importantly, as from this study is when after the distension, there is a higher accuracy for like most compared to the without the distension of the stomach. So, so proper gastric distension may help to increase the accuracy of the diagnosis. And more recently, there has been some new subtyping of the gastric cancer, and so accordingly to these subtypes, there has been also studies to show what are the glucose metabolism difference in these subtypes. And from a study, it showed that the EBV positive cancers have high FDG avidity compared to the EBV negative. And the reason why is actually not unknown, but one possible explanation could be in the EBV positive, there can be a dysregulation of one or more metabolic signaling pathways. And previous studies have shown that PIK3, the gene encoding the catalytic subunit, is mutated in this EBV positive gastric cancer, which can result as a high FDG avidities. And also, the MSI, the microsatellite instability, which has gained a importance because of the hype of the immunotherapy. And in the stomach cancer, gastric cancers, the microsatellite instability is recognized to have higher FDG uptake compared to the microsatellite stable cancers. So the link between this MSI and the glycolytic activity is, I think, to be due to the inflammation, because these microsatellite instability cancers have more immune infiltration in the cancers, which will have more FDG accumulation. So not a tumor cancer cells uptake, but it can be due to the high FDG uptake in the macrophages or tumor-related inflammatory cells. However, it's still preliminary, so I think many studies can be done according to this subtype of the gastric cancers. Okay, now we can move on to the lymph node. One thing to note is that so the lymph nodes in the gastric are usually defined as a station, like regional nodes, and which we recall in the reading as a perigastric nodes, and it is composed of 6 nodal stations, and we will review it in the back. And there are other regional lymph nodes, which is also 6 lymph nodes, which is regional. And there are other lymph nodes which can have more many chance of metastasis, but which is defined as distant. One thing to note is that the superior mesenteric vein lymph node station is considered regional by the Japanese Gastric Cancer Association, but it is defined as a distant metastasis according to the 8th edition of the AJCC. And the hepatoduodenal ligament here, it was classified as a distant metastasis in the 7th edition of AJCC, but however, now it is classified as a regional lymph nodes. So more closely, we can see how the lymph nodes are classified according to the CT anatomies. So firstly, we can see right pericardia and left pericardia, and right pericardia and these proximal side of the lesser curvature lymph node have a drainage from the left gastric artery, and the distal part of the lesser curvature lymph node along have a drainage from the right distal gastric artery. And there are also regional lymph nodes, perigastric lymph nodes in the pyloric area, and suprapyloric lymph nodes have a drainage from right gastric artery, and infrapyloric artery has a drainage from the proximal right gastroepiploic arteries. And the great curvatures have is shown along the drainage of the short gastric artery. So when you see some lymph nodes near the stomach, we can recall it as there are perigastric lymph nodes. And the second tier perigastric lymph nodes are, as you can see, there are 6 lymph nodes, and they're the left gastric. So left gastric artery trunk is seen along the proximal, as the name, proximal left gastric artery. And the common hepatic artery is, as the name, it goes by the common hepatic artery, and the celiac trunk is in the celiac trunk. So it's before it divides into common hepatic artery, we can recall it as a celiac artery trunk nodes. And there is a hepatoduodenal ligament, and it is when there is a lymph node along the hepatic arteries, we can recall it as a hepatoduodenal ligament lymph nodes. So these are the second tier perigastric lymph nodes. And also there are 2 more splenic hilar and splenic artery lymph nodes, which is also a regional, second tier regional lymph nodes. So why before? So according to the location of the primary tumor, there is some differences in the frequently involved lymph nodes. So firstly, the lesser or greater curvature lymph nodes can be invaded by the tumors regardless of the tumor location. But in the tumors in the upper third of the stomach are more likely to show a involvement in the paracardial and celiac and splenic hilar or splenic artery areas. And in the tumor, beside tumors in the lower third have more chance to involve the pyloric area lymph nodes, and also common hepatic artery and superior mesenteric vein lymph nodes. And tumor in the middle portion can spread into the either side. And in the CTs, in the stagings, the importance is the number of the metastasis. So they, by the number, it is classified. And in the CT, usually the positive lymph node criteria are when the short diameter is longer than 8 millimeter, and there is a cluster of like 3 perilesional nodes and strong enhancement or necrosis. They recall it, as you can see, like necrosis. So you can recall it as a positive lymph nodes. For the FDG PET CTs, the staging of the local regional lymph nodes are limited because of the height. There can be a physiologic uptake of the stomach, or because of some limitation of registration or the small size. So usually the sensitivity is low for detection of the regional lymph node, but the specificity is high. But compared to the regional lymph node, the performance is quite higher for the detection of the more N2 or like more other second tier regional lymph nodes or distant lymph nodes. The detection rates, accuracies are higher, but still the sensitivity is very low. So when I read a initial staging of the stomach cancer patient, if there is a small lymph node, we just recall there can be although there is no FDG uptake, we can recall that there is a paragastric nodes and it can be a metastasis. The reason why we recall that there is a chance of gastric lymph node metastasis is that still, regardless of our information, they can do the surgery. They do the surgery and dissection of the local regional lymph node. So the low sensitivity might not have that much clinical importance. However, because of the high specificity, I think there is a role of FDG PET, because if there is a distant lymph node metastasis, and because the specificity is high, we can actually have a clinical impact for changing the treatment strategy for the patient. Like degree, we can change extending the degree of lymphodectomy or reducing the futile laparotomies. As you can see, usually the D2 dissection is done, which is a extended dissection of local regional lymph nodes are done in most cases. So actually, very accurate diagnosis of the regional lymph nodes may not be that much important, but still, our high specificity of the FDG PET can give some more impact for changing the strategy of the treatments. And one more point of the thing is that FDG uptake of the lymph node is significantly correlated with the uptake of the primary tumor. So if the primary tumors have a high SUV, there might be more chance of high SUV FDG abilities in the lymph nodes. And finally, we can see the M staging, and the most frequent metastasis from the stomachs are liver, because the drainage is the stomach also have a portal vein drainage, so there is a high chance of liver metastasis, and also because of the ligaments, and there can be a high chance of spreading in the peritoneum. Seeding can be frequent. And less frequently, there can be a lung and bone metastasis. And for the M staging, FDG PET has quite a lot of role. And however, the sensitivity is very low compared to the CTs. Right? And the specificity, however, is high compared to the CT scan. And occult metastasis, the PET has in the AGC patient, it is reported that detection rate of occult metastasis was 10%, which can be result in cost saving in the patient. So the PET-CT may play an important role in changing the treatment strategy, which is similar to the lymph node metastasis also. But still, we might need to remember that the sensitivity for detecting the peritoneal seeding is quite low for the PET. So although there is no significant FDG uptake in the infiltrative lesions in the peritoneum, we still have to consider the chance of if we see although it's non-contrast CT, if there is some findings of the peritoneal infiltrations, we might need to recall, regardless of FDG ability, as the chance of the peritoneal seeding. But before, we might need to also know where are the high chance, where we need to see more carefully when we read a FDG PET-CT. So the peritoneal cavity is divided into several anatomic compartments by the ligaments and mesenteries. Firstly, the peritoneal cavity is divided into supra and inframesocolic. The supramesocolic compartment is divided into the bilateral subphrenic space and subhepatic space, continuing into the lesser side. And the inframesocolic compartment is divided into left and right region by the mesenteries. And so the movement of these peritoneal fluid ascites is within the peritoneal cavity is determined by the peritoneal compartment. And when you also read and make a reading, you might need to write, describe the location of the if there is a peritoneal lesion. You can follow this kind of according to the anatomic compartments. And the frequent locations for the peritoneal seedings are in the peritoneal reflections, like lower small bowel mesentery, sigmoid mesocolon, and right paracolic gutter, right subphrenic space, and greater omentum. So these regions should be more carefully reviewed when you read staging stomach cancer PET-CTs. So for other like metastasis, FDG have a high, quite clinical, can give some clinical impact. So there was a upstaging of like 20% of the advanced stomach cancer patient, and among these upstage patients, 17 showed distant metastasis not evident on other imaging, which will have a significant change for the treatment strategy. And another thing we might need to see is that most of the type were like intestinal type, which will have a high FDG avidity in the primary tumors. So the thing is that FDG uptake in the metastasis is also related to the FDG avidity of the primary tumor. So if the lesion, if the primary tumor has a characteristics of higher FDG avidity, there can be more chance of lymph nodes or distant metastasis to have a high FDG uptake. Okay, this case is about 70-year-old male patient, had a advanced gastric cancer and had a laparoscopic distal gastrectomy. And the pathology was tubular adenocarcinoma, moderately differentiated, and Laurent type of intestinal type. However, after the surgery, from the follow-up, there was a suspicious lymph node in the CT scan in 2000. 3 years later. So the patient have underwent PET-CT to find out whether there is a real nodal metastasis. So just reviewing, you can see some mucosal impact, suggesting some maxillary sinusitis, and sorry. So there is also some mild hypermetabolism in the anastomosis site of the surgery, but which seems to be more likely to be a physiologic uptake in the anastomosis site, because there are no definite thickening in the stomach walls. However, below there is a focal hypometabolic lymph node in the mesentery area. So this was the same lesion which the CT scan recalled as the suspicious lymph node. And we think that this might be a metastasis. So according to the pathology, we can think that this primary tumor should have a high FDG ability, and as you can see, so there can be more chance that this lymph node can be a metastasis. So the omentectomy and lymph node dissection was done, and it was confirmed as a metastatic adenocarcinoma. Another case is that a 74-year-old female patient was referred because of peritoneal infiltration in the CT scan. Firstly, abdominal distension, and from the CT scan, they have found a peritoneal infiltration. So to find out what is the reason for the peritoneal carcinomatosis, they have done like CTs and PET imaging. So you can see there are some ascites in the abdominal cavities, and looking through, there is a diffuse thickening of the stomach from the body to the antrum, and with which is Bormann type 4, diffuse type, which seems to be diffuse type gastric cancers. And there are also infiltration mass-like soft tissue lesions along the omentum. As you can see from here, there are many nodular and soft tissue lesions along the omentum, and still the ascites are also seen in the pelvic cavities and in the subhepatic areas and then perihepatic areas. And in the CT scan, PET CT, you can see also some hypometabolic lesions along the perisplenic and omentum areas and paracolic gutters, and also in the pelvic cavities there are some ill-defined hypermetabolic lesions, which is suggestive of peritoneal carcinomatosis. However, one thing is that there is also, we can see a thickening in the diffuse thickening in the stomach distal part. However, there the uptake was low. And as we have seen that diffuse, like Bormann type 4, diffuse infiltrative cancers can have low FDG ability, but however, the peritoneal lesions have high FDG ability, which has some different metabolic characteristics. So although there can be more chance of like gastric cancer with peritoneal seeding, we recall that there can the characteristics are different. So the pathology of this omental and this peritoneal lesions might be different. So the EGD and also laparoscopy was done. And interestingly, we still think that EGD find only a chronic gastritis, but we think there is a underlying like infiltrative cancers. But more interestingly, from the diagnostic laparoscopy, the patient was found as a metastatic carcinoma, and in the immunohistochemistry, they refer that it is less likely to be a gastric cancer, but more likely to be a ovary or primary peritoneal carcinomatosis. So as reviewed, that if there is a difference in the like glucose metabolic characteristics, there can be also chance of different pathology in like this case. So for the recurrence to detect the recurrence, FDG PET has quite high sensitivity and specificity, like 85% and 78%. And still, so the more importantly, what I want to show is that it is important that to gastric distension is needed because the local recurrence is most likely to occur in the left gastric or in the anastomosis site. So proper distension is also important in these cases. So gastric distension is not only important for the detection of in the initial staging, but also if in case of partial gastrectomy, it is important to dilate properly for the detection of the tumors. So as you can see there, however, one thing was that in false negative case, there was a false negative case, and after the before there was a high FDG uptake, but after the distension, it's gone away. So they have read this case as a negative. However, it turned out to be a signal ring cell carcinoma, which may have low avidity. So this type of so although in the recurrence also, if there is a characteristic of low FDG avidity, it can be hard to correctly diagnose or detect the recurrent lesions. Okay, so actually this is the result from the case 3, and as you can see, so the importance is when you read a case of a recurrence, the thing you need to remember is the tumor characteristics and the pathology should be considered and reviewed whenever you read for the stomach cancer recurrence image. And actually, it is good if it is available to always review if initial PET-CT stage which was used for the staging, then we can easily know the tumor characteristics. Okay, and this FDG PET also can be used for the response evaluation, because CT treatment response can be underestimated by the treatment-related changes such as like fibrosis, necrosis, and inflammation and edema. So since the changes in the glucose metabolism can precede the changes by the morphologic changes, so this FDG PET can be an early and sensitive marker for the tumor response. And this study showed that if it is classified to the responder to the non-responder, as you can see, metabolic responders showed a longer, better survival compared to the non-responders. Okay, lastly, what I want to discuss is that for the stomach cancer, there has been many studies regarding a new imaging agent, which is the FAPI PET. And this is data from the TCGA pan-cancer analysis. And you can see that, and this is the expression levels of the FAP, and as you can see, the highest uptakes are seen in pancreatic cancers or sarcomas. However, also the gastric cancers have stomach adenocarcinomas have relatively high FOB expression, which can be a good candidate for FOP imaging. So, and more on the benefit of using FOP PET in stomach cancer is that because in the stomach volume is higher, so it can be more sensitive, and because the FDG avidity is significantly low in the gastric cancer in most cases, so it can be also very effective. And mostly in the lower, because of the low normal physiology uptake, like the gastric cancers have a high metastasis rate to the liver, so it might be better to detect a tumor liver hepatic metastasis. And like other advantages are we can like get the image because of the fast tracer kinetics, like within an hour we can get the image. So this study reported in the radiology is about the efficacy of FOP PET in the GI cancers, and they have evaluated gastric, duodenal, and colorectal cancers. And as you can see, firstly, the detection rate is very high compared to the FDG PET, and especially for the gastric cancer, it has a good performance. And the SUV was, as you can see, is normally low in the gastric cancer, and as previously mentioned, also it is lower in the signal ring cell carcinoma compared to the adenocarcinoma. However, the SUVs in the FOP is shown to be high compared to the FDG uptake, so which makes it better to detect the primary and also the lymph node or distant metastatic lesions. So these are some cases of representative cases, and you can see that from 55-year-old male patient with a known signal ring cell carcinoma. So you can see a FOP uptake along the gastric wall in the upper body. However, there is no significant discernible uptake in the FDG PET. And also this is a recurrence case of a 48-year-old male patient who underwent radical gastrectomy. And the pathology was also signal ring cell carcinoma. And recurrent lesions in the FDG PET shows very subtle or no discernible hypermetabolism. However, FOP PET shows high uptake and also like lesions not detected in other imaging. And also a study has been conducted using the PET-MR, and it has shown a better performance for detecting the gastric cancer. And similarly, as you can see, compared to the FDG PET, it has a higher uptake. And some interesting points are it is higher in the tumors with a larger size, or it is also there is some relationship according to the tumor size and depth of the invasion. However, there is no significant difference according to the histology type or the degree of differentiations. So usually the bigger samenly to the FDG PET, the FOP PET also has a show higher uptake in the bigger tumor, but still compared to the FDG PET, the lower size tumors can be better detected by the FOP PET compared to the FDG PET. which showed a 71% of sensitivity, however, like higher of 100% of sensitivity. And lastly, so this study was to investigate the role of the FOPI PET imaging in the primary or metastatic gastric sigmoid ring cell carcinoma. So this is a cohort of multi-center study only with the sigmoid ring cell carcinoma, and 34 patients were evaluated. And as you can see, that FOPI PET showed greater radiotracer uptake, tumor to background ratio, and higher diagnostic accuracy for the primary or recurrent tumors and metastatic lesions. So according to the what kind of lesions, there was a higher performance of FOPI PET for peritoneal seedings or liver or lung metastasis, and also lymph node metastasis, but no significant change, equal performance in the adrenal metastasis. There has been some lymph node of the mesothelioma of the or abdomen or bone metastasis, which the FDG showed higher superiority in some cases, but mostly the FOPI PET outperformed the FDG PET. So I believe that for the stomach cancer, FOPI PET may have an important role for the diagnosis, for the staging workup, and for the also the recurrence workups. So we are actually now preparing a conducting a study for the stomach cancer, and compare the FOPI uptake according to the histopathologies. So compare with some subtypes of the gastric cancers, how they are different. Okay, so for the gastric cancer, we have seen how the T stagings, N stagings, and M stagings are done, and how the lymph nodes, how the FDG PET can have a role in these stagings or recurrence. And also, so firstly, when you do a gastric cancer study, the most important thing is to gastric distension can help the diagnosis. And another point for the FDG PET is that tumor characteristics should be considered, because there is a difference in the FDG ability according to this tumor histology or subtypes. And lastly, the FOPI PET can be a very useful diagnostic tool for the gastric cancer, especially like tumors with low FDG ability, such as sigmoid ring cell carcinoma, and may have a better diagnostic accuracy. Okay, so this might be the end of my presentation. So thank you very much. And would there be any questions or comments? Okay, if there is no questions or comments, I think we can end the session now. And I think there will be a following lectures from our colleague from next week. So I think you can also enjoy the lectures from our colleagues. Okay, thank you very much, and see you next week, next Wednesday. Thank you.